You know that feeling, just drowning in information when you're trying to tackle something complex.
Oh, definitely.
So especially something like healthcare, right?
Yeah.
It's huge, it's vital, maybe a bit intimidating. You sort of wish you had a guide, someone to point out what really matters.
Yeah, I think that's a really common experience. The sheer volume, it's immense. But moving past that feeling, getting to where you feel genuinely informed, like you're seeing the critical path professionals take. That's the aim.
Exactly. And that's what we try to do here on the Deep Dive. We take source material, and today it's, well, foundational text professionals lean on, and we dig deep. We pull out the insights you need to really master the topic, not just float on the surface. Consider us your fellow explorers today.
And the source for this particular dive, it's straight from Bailey and Love's Short Practice of Surgery. We're looking at excerpts focused squarely on postoperative care and this concept of perioperative optimization. It's the kind of stuff that really underpins professional understanding.
Right. And our mission today is specific. We want to understand the whole journey around surgery, not just the operation itself. We're going to unpack the care, the potential pitfalls, especially after the surgery, and crucially, how professionals think about managing those risks. It's about seeing surgery as this whole integrated process. Preparation and recovery are just as critical.
So over this deep dive, we'll be getting into that team approach, the immediate post-op steps, how complications are predicted, classified, how they're managed system by system, and even strategies to, speed up recovery. This isn't just a quick summary. It's about getting into the details needed to feel genuinely competent understanding this whole area.
Okay, brilliant. Let's dive right in. Perioperative care, the big picture, that term. What does it actually mean in practice? Beyond just the surgery bit.
Well, fundamentally, perioperative care is the integrated care provided by a whole team, a multidisciplinary team covering the time before, during, and critically after the surgical procedure. Integrated is the key word there. It's meant to be seamless.
And this team, who are we talking about? Who's involved in guiding the patient through this?
It's quite a broad group, actually. You've got the surgeons, obviously, anesthetists, doctors specializing in acute medicine, maybe geriatricians for older patients, cardiologists if needed, and then absolutely vital roles played by nurses, physiotherapists, occupational therapists.
Right.
The exact mix, who's heavily involved, really depends on the patient's own health and how complex the surgery is planned to be.
So the goal is bringing all that expertise together, with the patient involved too, to get the best possible outcome.
Yeah.
And also, I guess, manage healthcare resources effectively, reduce costs.
That's exactly it. And if we're talking about mastering this, a really fundamental insight is just how valuable that pre-surgery phase is, that window between deciding to operate and the actual surgery date. It's not just waiting around.
Okay, so what makes that window so critical? What's happening then?
It's the prime opportunity for really thorough risk assessment. And crucially, identifying and treating any existing medical problems the patient might have before they face the stress of surgery. The idea is optimization.
Optimization. Getting them in the best possible shape beforehand. Why is that so important? What happens if you skip that?
Well, look, many patients have underlying chronic conditions, diabetes, heart problems, lung issues. Surgery puts immense stress on the body, and it can really aggravate these conditions. Optimizing beforehand helps prevent that deterioration during or after surgery.
I see.
Which in turn means fewer complications and fewer delays getting the patient home, which is better for everyone and the system. It's about building resilience before the challenge.
How deep does that risk assessment go? What sort of tests or evaluations are we talking about?
It can range quite a bit. Sometimes it's relatively simple things like blood tests, checking for anemia or kidney function or early signs of heart strain. But for more complex surgeries or patients with more health issues, it can involve quite sophisticated tests like cardiopulmonary exercise testing, CPET.
Yeah.
It gives a really detailed picture of how fit the patient is physiologically speaking.
Yeah.
They're reserved to handle the surgery.
Okay, so you've got this crucial prep phase, and then during the surgery itself, obviously high-quality care is expected. That's a given. But preventing harm from errors is also a massive focus, right?
Absolutely massive. And this is where standardization becomes, non-negotiable, really. Things like checklists, the WHO's surgical safety checklist is mentioned specifically, are just routine practice now, designed precisely to prevent errors during the operation itself.
Makes sense. What about postoperative pain? That's always a big worry. How does the perioperative approach tackle that?
Pain isn't just unpleasant, it's a real obstacle. It stops people moving, which increases risks like chest infections. It can even lead to chronic pain down the line, and it just makes for a poor experience overall.
Yeah.
So a well-trained team, often led by the anesthetist, develops a specific pain management plan for each patient. They anticipate the needs based on the surgery, the patient's history. It's very individualized.
It's interesting the source mentions anesthetists taking on a broader role, managing complex patients throughout the whole perioperative period. What's the rationale there?
Well, it comes down to their deep understanding of physiology, how drugs work, how the body responds to the stress of both anesthesia and surgery. They're uniquely positioned to anticipate and manage the complex physiological bumps in the road that can happen.
Okay, so after the surgery is done, patients don't always go straight back to a regular room, do they?
Right.
There are special units.
That's right. For patients who've had very complex surgery or maybe have significant underlying health problems, they often need more intensive monitoring than a standard ward can provide, but perhaps not full-on ICU level care.
So like an intermediate step.
Exactly. That's where you get overnight intensive recovery units or the PACU, the post-anesthesia care unit. They might stay there for, say, 24 to 48 hours for closer observation, more frequent checks, that sort of thing.
And then from PACU or OIRU, where next?
It depends entirely on how they're recovering and what level of support they still need. They might step down to a standard surgical ward, or if they still need significant help, perhaps with breathing or heart function, they could be transferred to a critical care unit.
And all this fits within that idea of using hospital resources efficiently too, right? Getting people home safely, but without unnecessary delays.
Precisely. Efficient flow, good discharge planning that actually starts quite early on. It's all part of the operational side. And good communication with community services like GPs or district nurses is essential for that smooth transition home.
You mentioned optimization before surgery, improving function. The source calls this prehabilitation, getting ready for surgery. What does that actually involve? What are patients asked to do?
Prehabilitation. Yeah, it's a proactive strategy. The whole point is to improve a patient's functional capacity before they have major surgery. The thinking is if you boost their physical and physiological reserves going in, they'll cope better and recover faster afterwards, especially important for people starting out a bit frail or deconditioned.
And this happens in that window between the decision and the surgery date.
That's the window of opportunity, exactly.
So what does the medical optimization part look like in practice?
It's quite varied. It definitely includes lifestyle stuff, encouraging smoking cessation, cutting back on alcohol, weight loss if needed. Treating anemia is critical. Low blood count impacts oxygen delivery.
Right.
And then for chronic conditions like diabetes, asthma, high blood pressure, it's about really tightening up control, reviewing medications, adjusting doses, making sure those conditions are as stable as possible before the surgical stress hits.
How do they measure that functional capacity you mentioned? Is it just subjective?
No, they can use formal tests. We mentioned CPET before. That gives detailed physiological data. A simpler, common one is the 6-minute walk test, basically. See how far someone can walk in 6 minutes? It gives a good baseline measure of their endurance.
And actual exercise is part of it.
Oh, yes. Patients are often encouraged, sometimes prescribed, specific exercises, usually a mix of strength training and aerobic exercise to build fitness.
Nutrition gets mentioned too.
A really crucial mention. Being poorly nourished before surgery is strongly linked to worse outcomes, slower healing, more infections. So identifying and correcting any nutritional problems beforehand is a key part of preparing someone properly.
And it's not just physical, there's a psychological element.
Absolutely. Surgery is stressful mentally, not just physically. So support to reduce anxiety beforehand and perhaps boost motivation for the recovery afterwards. That can make a real difference to the patient's overall journey and outcome. It's a holistic approach, really, preparing the whole person.
Okay, makes sense. So the patient's been prehabilitated, optimized, they've had the surgery. Now we hit the postoperative phase, handoff and initial monitoring. Where does this phase officially kick off?
It starts the moment the surgery ends and the patient is transferred out of the operating theater, usually to the recovery room or, as we mentioned, the PCU.
And is there a formal handover at that point? It seems critical.
Oh, absolutely critical. It's actually built into the WHO surgical safety checklist. There's a formal sign-out process. The team from theater, surgeon, anesthetist, nurses hands over care systematically to the PCU staff. Continuity and safety depend on it.
What information has to be conveyed in that handover? What are the key bits?
It needs to be thorough but efficient. You need the patient's identity, definitely. Name, age, the exact operation performed, details of the anesthetic given, any painkillers used, how much fluid they received, estimated blood loss, urine output during the case, any problems that came up during surgery, any issues they anticipate might happen in recovery. Plus, their existing medical background allergies, chronic conditions, and, really importantly, the plan for managing pain and nausea or vomiting after the surgery.
Got it. So, patient arrives in PCU. What's monitored immediately? What are the priorities?
The focus is squarely on vital signs and basic functions, so continuous monitoring, pulse, blood pressure, oxygen saturation using the pulse oximeter. Staff are assessing their level of consciousness constantly as they wake up, checking their pain levels, their hydration, and giving supportive treatment as needed, maybe some oxygen IV fluids.
And the source highlights this idea of observations being collected into early warning systems. That sounds important for mastering this.
It's fundamental. Observations aren't just jotted down. They feed into structured systems designed specifically to flag early signs that a patient might be deteriorating clinically. This starts right there in recovery and continues right through their stay on the ward until discharge.
The key example given is the National Early Warning System, NEWS2. What parameters does it track?
A new WS2 uses 6 pretty simple standard physiological measurements. Respiratory rate, how fast they're breathing, oxygen saturation, systolic blood pressure, pulse rate. Their level of consciousness, crucially noting any new confusion, disorientation, or agitation. And temperature.
How did that turn into a score?
Each of those 6 measurements gets a score based on how far it deviates from the established normal range. The further off, the higher the score for that parameter. And importantly, if the patient needs supplemental oxygen just to maintain their saturation, that adds an extra 2 points right onto the total score. Then you just add up the scores for all parameters to get one aggregate NWS2 score.
Okay, an aggregate score. How does that then guide the team? What does the number actually mean in terms of risk and response?
The score directly translates into a level of clinical risk and mandates a specific type and urgency of clinical response, including the skill level needed from the responding staff. A low score, say 0 to 4, indicates low risk, usually managed with standard ward monitoring. A score of 5 or 6 suggests low, medium, or medium risk. That triggers an urgent response from the ward team, who need to be competent in assessing acutely unwell patients and knowing when to escalate, maybe call for critical care import. Then a high score, 7 or more, signifies high clinical risk. That demands an urgent or emergency response, typically from a critical care outreach team or equivalent. These responders must have advanced skills, including airway management capabilities.
And is there like a single bad reading that sets off alarms too?
Yes, that's the red score. If any single parameter scores 3 points, which means it's significantly deranged, that triggers an immediate urgent response, even if the total aggregate score is low. It's a specific flag for a major problem in one system.
Beyond those NWS2 vitals, are there other specific observations needed depending on the surgery?
Oh, absolutely. For certain operations, you need extra checks. For example, after plastic surgery involving a free flap moving tissue with its own blood supply, they'll do regular Doppler checks to make sure blood is flowing to the flap.
Right.
After brain or spine surgery, regular neurological checks are vital. And sometimes specific lab tests like blood gases are needed, depending on the situation.
So the patient's being closely watched in PCU.
Yeah.
What are the specific criteria for PCU discharge? When is it actually safe for them to move to, say, a regular ward?
There's a clear checklist they need to meet. They need to be fully conscious and alert. Their breathing and oxygen levels must be satisfactory without needing excessive support. They should be normal body temperature. Their pain needs to be adequately controlled, or at least at an acceptable level for them. They shouldn't be feeling overly nauseous or vomiting uncontrollably. Cardiovascular signs, pulse, blood pressure need to be stable. And importantly, all the necessary prescriptions for things like oxygen, fluids, pain relief for the ward must be written up clearly. And finally, there shouldn't be any lingering concerns related specifically to the surgical procedure itself that warrant keeping them in PCU.
Is that the case for everyone? Or are there exceptions?
There are exceptions. As we mentioned, patients who've had very major complex surgery or those with quite severe pre-existing health conditions might stay longer in PCU or an overnight intensive recovery unit, maybe 24, even 48 hours. Then they'd move either to the ward or potentially to critical care if they still need that level of support.
Okay. Now let's shift gears a bit and talk about something that's, well, an unfortunate reality. Postoperative complications. How big a deal are they?
They're a very big deal. Complications are a major cause of illness, sadly sometimes death, longer hospital stays, and consequently higher healthcare costs. Understanding complications is absolutely core to mastering postoperative care.
Can you actually predict who's more likely to run into trouble?
Yes, and that's a really crucial part of modern perioperative care. Most patients who are at a higher risk can be identified before their surgery. Usually this happens in the preoperative assessment clinic. They use various validated scoring systems and risk calculators.
Could you give an example of one of those tools?
Sure. The source mentions one called the ACS NSQIP Surgical Risk Calculator. That's the American College of Surgeons National Surgical Quality Improvement Program. It uses patient factors and the planned operation to estimate the risk of specific complications.
And identifying that risk early. Why is that so powerful?
Because it allows the whole clinical team to be proactive. They can put targeted preventative measures in place. They can provide more focused supportive care, anticipating potential problems. It's about shifting from reacting to complications to actively trying to prevent them or lessen their severity, and that demonstrably improves outcomes. It's fundamental.
The source talks about classifying the severity of complications using the Clavian-Dindo classification. What's that about?
Right, Clavian-Dindo. It's a system that's become pretty standard globally. It provides an objective, repeatable way to grade how severe a complication is, how much impact it had.
Okay.
The really clever and key insight behind it is that it grades complications based on the treatment that was needed to manage the complication rather than just describing the complication itself.
Right.
This helps reduce subjective bias in reporting.
So the grade reflects how much intervention was required.
Exactly. It ranges from grade 1 to V. Grade 1 is any deviation from the normal course, but requires no extra drugs beyond simple things like pain relief, anti-nausea meds, maybe basic physio, or opening the wound slightly at the bedside. Grade 2 needs other medications like antibiotics for an infection, maybe blood transfusion, or TPN, which is intravenous feeding. Grade 3 means an intervention was needed. 3, there is intervention without general anesthesia, like draining an abscess under local anesthetic. 3 requires intervention under general anesthesia, like returning to the operating room. Grade 4 is life-threatening, needing ICU care. IVA is single-organ dysfunction managed in ICU. IVB is multi-organ dysfunction in ICU. And grade 5, sadly, is death resulting from the complication.
That structured approach must be really useful for comparing outcomes. What about the timing of complications? Do they all happen right away?
No, not at all. Complications can pop up anytime, minutes after surgery, days later, even weeks after discharge sometimes. But yes, certain types of complications do tend to cluster at specific times. There are patterns. For instance, immediate airway issues are common right as anesthesia wears off, whereas wound infections typically show up several days later.
And how are complications usually grouped for discussion?
Typically, they're looked at in 2 main ways. System-specific, so problems affecting the respiratory system, cardiovascular, renal, etc. And then surgery-specific complications, which are particularly relevant to certain types of operations, like abdominal surgery or orthopedics.
Okay, great framework. Let's really dive deep into system-specific complications now. Starting with the respiratory system, how are problems picked up early post-op?
Vigilance, really. Constant vigilance. It starts with basic checks. Is the airway clear? How fast are they breathing? What's their oxygen saturation on the pulse oximeter? These checks are especially intense during emergence from anesthesia and in that initial PCU phase.
And these respiratory issues can happen right away or develop later.
Both. You can get immediate problems in PCU, or things can develop later on the ward, sometimes even after the patient's gone home. The timing varies.
What are the common immediate issues seen in PCU?
Probably the most common thing right at the start is upper airway obstruction. The tongue falling back is classic, especially as anesthesia wears off. But it can also be residual muscle relaxation from drugs, swelling in the airway tissues, maybe a hematoma forming and pressing on the airway, problems with vocal cords, even a foreign body like a dislodged tooth fragment.
So quick action needed.
Absolutely. Simple things like a jaw thrust maneuver or putting in an oral or nasal airway can be life-saving. Needs immediate recognition and intervention. Another common one is hypoventilation, basically, not breathing enough, often due to leftover effects of anesthetic drugs like muscle relaxants, inhaled agents, or strong opioids. You spot it by watching the breathing rate and the oxygen saturation. Treatment is usually just giving supplemental oxygen until they're breathing adequately on their own.
And hypoxemia, low oxygen levels. What causes that, other than obstruction or slow breathing?
Yeah, hypoxemia can have other causes too. Acute pulmonary edema fluid on the lungs can happen, maybe from getting too much IV fluid or underlying heart failure, or sometimes even after relieving an airway obstruction suddenly. Other causes include bronchospasm, aspiration, breathing in stomach contents, which is serious, a pneumothorax, which is a collapsed lung, or sometimes, though less commonly right away, a pulmonary embolism. A really key clinical insight here is that patients with existing conditions like obstructive sleep apnea, chronic lung disease like COPD or obesity are particularly vulnerable. They can desaturate, their oxygen levels can drop very quickly. They need extra close watching.
If someone's breathing on their own, but their O2 is low, what's the immediate response?
High flow oxygen straight away, usually 15 liters a minute through a non-rebreather mask. Then basic airway maneuvers, head tilt, chin lift, jaw thrusts to make sure the airway is open, maybe suctioning if there are secretions, maybe an oropharyngeal airway, and getting the anesthetic team involved early if things aren't improving quickly. And the source flags some specific life-threatening airway issues after head and neck surgery, vocal cord palsy from nerve injury, a rapidly expanding mech hematoma, or severe post-tonsillectomy bleeding. All demand immediate, urgent action.
Okay, moving beyond that immediate PACU phase.
Yeah.
What about respiratory problems cropping up later, on the ward or after discharge?
Yeah, these are a major source of problems. Illness and even death after surgery. The incidence can be surprisingly high. The source says maybe 5% up to even 70%, depending on the surgery and patient factors.
Wow, what kinds of problems?
Things like postoperative fever, often initially blamed on tiny areas of lung collapse called microatelectasis. Cough, shortness of breath, wheezing, or bronchospasm. High CO2 levels, which is hypercapnia. More significant lung collapse, atelectasis. Pneumonia, obviously. Fluid around the lung, a pleural effusion. Collapsed lung, pneumothorax. Or even full-blown respiratory failure.
Can you tell beforehand who's most likely to develop these later lung problems?
Yes, largely. This is where that preoperative assessment is so vital again. You can identify most high-risk patients. Modifiable factors are key targets. Smoking is a big one. Poorly controlled COPD or asthma. Obstructive sleep apnea. Obesity, higher BMI. Other non-modifiable factors include age, being male, higher ASA score, which reflects overall health, being frail, having an infection beforehand, anemia, low baseline oxygen. And the type of surgery is huge. Thoracic chest surgery and upper abdominal surgery carry the highest risk by far. Longer operations, emergency operations, also increase risk. Identifying these patients lets you put strategies in place before and after surgery to try and mitigate that risk.
Okay, that's a really thorough look at respiratory. Let's switch systems to cardiovascular. How common are heart risk factors in surgical patients?
Actually quite common. The source says around 30% of patients having non-cardiac surgery have at least one significant cardiovascular risk factor. And within that group, the risk of a major cardiac event, like a heart attack, leads to a 30-day mortality rate somewhere between 0.5% and 2%. So it's significant.
How do they monitor the heart postoperatively to catch problems?
Standard monitoring includes pulse rate, blood pressure, and usually continuous ECG display, especially in PACU. For patients considered higher risk, maybe due to their history or the type of surgery, they might get extended monitoring, 24 hours or more, often in PACU or an HDU, a high dependency unit.
Let's talk blood pressure. Hypotension, low BP, that sounds like an immediate worry.
It's very common right after surgery, yeah. And if it's not corrected, it's definitely linked to worse outcomes. The usual suspects are things like hypovolemia, not enough volume, maybe from blood loss or just dehydration, or the heart muscle itself might be impaired, not pumping well, or vasodilation, where the blood vessels relax, often due to spinal or epidural anesthesia. But, and this is crucial, you always have to consider other potentially more sinister causes. Is there ongoing hidden bleeding? Is sepsis developing? Is it an arrhythmia, a tension, pneumothorax, PE, cardiac tamponade, even anaphylaxis? You have to think broadly. An interesting point the source makes is about diastolic dysfunction. That's where the heart muscle is stiff and doesn't relax properly. It's common, especially as people get older. These patients are really sensitive to volume changes. They can get very hypotensive if they lose fluid or develop pulmonary edema if they get too much fluid. Their hearts just don't cope well with swings.
How do you manage hypotension when it happens?
First, find the cause and treat it. But if the low pressure is causing signs that organs aren't getting enough blood, like low urine output, confusion, ECG changes suggesting the heart muscle isn't happy, slow capillary refill, then you need to act fast. Usually that means giving IV fluids, and sometimes using vasopressor drugs to squeeze the blood vessels or inotropes to help the heart pump harder.
What about the opposite? Hypertension, high blood pressure.
Also common post-op. Often it's driven by things like pain, anxiety, agitation. Maybe their bladder is full and causing discomfort if they have a catheter. Or simply their pre-existing hypertension wasn't well controlled going in.
And the risks of high BP.
It increases the risk of bleeding, especially from surgical suture lines. In severe cases, it could contribute to a stroke or put strain on the heart, leading to myocardial ischemia or infarction.
You mentioned myocardial ischemia infarction, ME or MI. in S. Who's most at risk for that?
Patients who already have known heart disease or multiple risk factors for it, undergoing major surgery, that's the high-risk group, and MENOS myocardial injury after non-cardiac surgery is a spectrum. It can range from just detecting some heart muscle injury via blood tests all the way to a full-blown heart attack.
What are the symptoms to watch for?
Well, you might get the classic chest pain, maybe radiating to the jaw or arm, nausea, shortness of breath, feeling faint. But, and this is a really critical point for mastering this many of these events, especially MINS, are actually silent in the postoperative period. The patient might not feel or report any typical chest pain at all.
So how do you diagnose them, especially the silent ones?
You rely on other things. ECG changes can be a clue, things like ST elevation, new bundle branch block, arrhythmias. But often, especially for what we call non-ST elevation MIs, the diagnosis hinges on serial measurements of cardiac troponin. That's a protein released when heart muscle is damaged. Tracking its level over time is key. If you suspect MI, getting a cardiologist involved early is essential. They might consider treatments to restore blood flow to the heart, like PCI, angioplasty, or thrombolysis, clot-busting drugs. But that's a really complex decision after surgery because of the bleeding risk. Needs careful discussion between cardiology and the surgical team.
Arrhythmias, irregular heartbeats, they can cause problems too.
Absolutely. They can cause low blood pressure, trigger myocardial ischemia, even lead to cardiac arrest. Management follows standard resuscitation guidelines.
Can you give some examples?
Sure. Tachycardia fast heart rate could be sinus attach, SVT, or atrial fibrillation. Causes, lots of things. Anxiety, pain, MI, low blood volume, sepsis, electrolyte problems, low oxygen. Treatment involves fixing the cause if possible and controlling the heart rate, maybe with beta blockers, amiodarone, or sometimes cardioversion if the patient's unstable. Bradycardia, slow heart rate, might be normal for some fit people. But post-op, it could signal hypoxia or be due to drugs like beta blockers or digoxin, or even raised pressure inside the skull. Treatment might involve drugs like atropine or glycopyrrolate to speed the heart up. The source also mentions watching out for a prolonged QT interval on the ECG. It can be caused by various things, but some people are predisposed due to genetics or electrolyte issues, and it increases the risk of dangerous arrhythmias.
Okay, system shift again. Let's tackle the renal and urinary system. Acute kidney injury, AKI, sounds serious postoperatively.
It is very serious. Perioperative AKI comes with significant mortality and morbidity. It actually accounts for about a quarter of all hospital-acquired kidney failure cases. And the death rate, particularly after big operations like heart or major vascular surgery, can be quite high.
How is AKI actually defined or staged after surgery? How do you measure its severity?
The definitions are based on changes in two key things: serum creatinine, which is a waste product measured in the blood, and urine output. The source highlights the KDIGO staging system, kidney disease, improving global outcomes as the standard way to classify AKI severity.
Can you walk us through those KDIGO stages? This seems like fundamental knowledge to master.
Okay. Stage 1 is the mildest. It's defined by either the serum creatinine rising to 1.5 to 1.9 times the patient's baseline level within 7 days, or having an absolute increase of 0.3 milligel or more within just 48 hours. Or, based on urine output, it's putting out less than 0.5 millimoles per kilogram per hour for 6 to 12 hours. Stage 2 is more severe. Creatinine increases to 2 to 2.9 times baseline. Or urine output drops below that 0.5 millibrew GA threshold for 12 hours or more. Stage 3 is the most severe AKI. Here, creatinine goes up to 3 times baseline or higher, or it reaches an absolute level of 4 milligel or more, or the patient needs renal replacement therapy like dialysis. In younger patients, a specific drop in calculated GFR also qualifies. The urine output criteria are even stricter, less than 0.3 milli-GHI for 24 hours or more, or complete anuria, no urine output at all for 12 hours or more. This staging really helps guide how aggressively you manage it.
Who's most likely to develop AKI after surgery?
Patients with pre-existing conditions, especially diabetes, are at higher risk. Those having emergency surgery are more vulnerable. And certain types of high-risk procedures, like cardiac surgery or organ transplants, carry a significantly increased risk of AKI.
And the causes of perioperative AKI? Yeah. The list looked pretty long in the outline.
It is, because surgery can impact the kidneys in multiple ways. The causes are usually grouped into prerenal, renal, and postrenal. Prerenal is the most common type perioperatively. It means the problem is before the kidney, usually reduced blood flow to the kidney. Think hypovolemia from blood loss or dehydration, sepsis causing vasodilation, heart failure or low cardiac output, high pressure inside the abdomen squashing the renal veins, liver disease, or clamping the aorta during vascular surgery. Renal causes mean the problem is within the kidney itself. This could be inflammation or damage from sepsis, existing chronic kidney disease making the kidneys fragile, exposure to toxins, either substances the body produces, like myoglobin for muscle breakdown, or external things like certain antibiotics or contrast dye used for scans. Blood transfusion reactions can affect kidneys too. Even the type of ID fluid used matters. Large volumes of fluids high in chloride, for example. Postural causes are blockages after the kidney, stopping urine flow. This could be related to the surgery itself, maybe in the urinary tract, or a tumor pressing on the ureters, an enlarged prostate, BPH in men, or problems with bladder emptying due to nerve issues.
Given how bad AKI can be, prevention must be key. How do you approach that?
Prevention starts with identifying those susceptible patients beforehand. Then, during the surgery, meticulous attention to maintaining normal fluid balance, normal volemia, and stable blood pressure is absolutely critical to keep blood flowing adequately to the kidneys.
Right.
Avoiding drugs known to be harmful to the kidneys whenever possible, minimizing unnecessary blood transfusions, and treating any infections promptly are also really important preventative measures.
The source made an interesting point about low urine output oliguria during the operation itself.
Yes, it specifically points out that it's common for urine output to decrease during surgery, and that this doesn't necessarily correlate with how well the kidneys are actually functioning at that moment. It warns against the knee-jerk reaction of just pouring in IV fluids solely to chase a higher urine output number during the case, because that can easily lead to fluid overload without actually helping the kidneys.
Okay. Shifting from kidney function to urine flow. Urinary retention seems incredibly common post-op.
It is remarkably common. The source quotes figures ranging from 5% all the way up to 70%, depending on the patient group and the type of surgery and anesthesia. Established risk factors include being older than 50, being male, having certain operations like hernia repair, anorectal surgery, or pelvic surgery. A history of prostate problems, BPH, or neurological disease also increases risk.
What contributes to it happening after surgery?
Several things can contribute. Spinal or epidural anesthesia and neuraxial blocks often cause temporary inability to void. Certain drugs used during anesthesia, like anticholinergics, some sedatives, opioids, can interfere with bladder function. And simply receiving large volumes of 5e fluids during the surgery can overwhelm the bladder's capacity.
How is it diagnosed and managed?
Often suspected based on patient discomfort, a feeling of fullness, or inability to pass urine. Clinical exam might reveal a palpable bladder. Ultrasound is commonly used at the bedside to actually measure the volume of urine retained. Treatment is necessary. It's uncomfortable, and prolonged retention can cause long-term bladder problems. The standard treatment is catheterization to drain the bladder, either intermittently or by leaving an indwelling catheter in for a period.
Are there times you'd put a catheter in before surgery to try and prevent this?
Yes. Prophylactic catheterization is often considered, or even standard practice. For longer operations, the source suggests maybe 3 hours or more, or when you anticipate giving large volumes of 5e fluids during the procedure.
What about urinary tract infections, UTIs?
UTIs are one of the most common hospital-acquired infections after surgery. Patients might present with dysuria, pain on urination, or a fever. Those who are immunocompromised, have diabetes, or a history of retention are at higher risk.
And management for a post-op UTI?
Pretty standard UTI management. Ensure good hydration, make sure the bladder's emptying properly, maybe need catheterization if retention is also present, and antibiotics. Ideally, the antibiotic choice is guided by urine culture results showing what bacteria is growing and what it's sensitive to.
Okay, let's move up to the head, the central nervous system. Postoperative delirium, POD. That comes up a lot, especially with older patients. What exactly is it?
Right, POD. It's an acute confusion state. Key features are reduced awareness of the environment and a disturbance in attention. This is usually accompanied by other things like hallucinations, disorientation, maybe temporary memory loss. It's distinct from POCD, postoperative cognitive dysfunction, which is more a general decline in thinking skills linked to surgery. The source just mentions that briefly.
When does delirium usually show up?
It can happen right as the patient is waking up in recovery, or it can develop seemingly out of the blue days later on the ward, even when they seem to be recovering physically.
How common is it? And who's most at risk?
The numbers vary quite a bit in studies, maybe 5% to 50%, but it's definitely much more common in elderly patients, and particularly after certain types of surgery like major orthopedic procedures, hip fractures, for instance, or emergency surgery.
What are the consequences if someone develops POD? Is it just temporary confusion?
No, it's not benign at all. Delirium is linked to worse overall outcomes, higher rates of morbidity, mortality, longer hospital stays. And sadly, it significantly increases the risk of patients needing discharge to a nursing home instead of going back to where they lived before.
Does it always look the same? Are there different types?
Yes, it can present differently. There's hyperactive delirium. The patient is restless, agitated, maybe pulling at lines, hallucinating. Then there's hypoactive delirium. They're withdrawn, quiet, lethargic, seem depressed, aren't engaging. The hypoactive type is often missed, but is just as serious in terms of outcomes.
What makes someone more likely to get POD? What are the risk factors?
They're usually divided into predisposing factors, things the patient brings with them, and precipitating factors, things that happen around the time of surgery that trigger it. Predisposing factors include any pre-existing cognitive problems, like mild impairment or diagnosed dementia, being frail, having Parkinson's disease, being severely ill generally, having kidney problems, or a history of depression. Then the precipitating factors, the triggers, are numerous. The source lists examples across systems. Kidney problems like renal failure, electrolyte imbalances like low sodium, UTIs, retention, lung problems like low oxygen or atelectasis, heart issues like PE, dehydration, shock, MI, heart failure, arrhythmias. Drugs are a huge trigger: opioids, sedatives, sleeping pills, alcohol withdrawal, hypoglycemia. Neurological events like seizures, stroke, head injury, even things like thyroid problems.
Wow, that list really drives home how many things can tip someone into delirium. How is it managed then?
The absolute cornerstone of management is identifying and correcting any reversible underlying causes from that long list. Treating the infection, correcting the electrolytes, optimizing oxygenation, tackling the trigger is key.
Right.
Beyond that, supportive care is important, making sure pain is well controlled. Having family or familiar faces around can help orient the patient, keeping the environment calm and consistent. Medications like haloperidol are really a last resort, used cautiously only for severe agitation where the patient is a danger to themselves or others, and always according to local guidelines. It's not a primary treatment.
What about stroke as a post-op complication?
Yes, stroke is definitely a recognized risk. It's a particular concern after carotid artery surgery, both early on due perhaps to clots breaking off, and sometimes later due to issues with blood flow regulation. Significant swings in blood pressure, high or low, are also linked to stroke risk after any major surgery.
And if a stroke happens, how is it treated given the recent surgery?
Treatment like thrombolysis clot-busting drugs might be an option, but it's a very high-stakes decision post-operatively. You have to weigh the potential benefit of restoring blood flow to the brain against the very real risk of causing major bleeding at the surgical site. It requires very careful discussion between the stroke team, neurology, and the surgical team.
And seizures.
Relatively uncommon after most surgeries, unless the patient has known epilepsy that's maybe not well controlled, or if the surgery was actually on the brain itself, neurosurgery.
Okay, we've covered the system specifics. Let's pivot to general postoperative complications, things that can happen after almost any surgery. First up, a big one, bleeding.
Yeah, postoperative bleeding or hemorrhage. It's a major concern, and it's most likely to declare itself in the immediate hours and days after the operation.
What causes it usually?
It could be a specific blood vessel, an artery or vein that wasn't properly tied off or sealed during the surgery and has started leaking. Or it might be more of a generalized ooze from the raw surfaces of the surgical area. Or sometimes the patient's blood clotting system itself isn't working properly, a coagulopathy.
The source mentioned a particular danger with slow bleeds.
Yes, that's a really important clinical point to grasp. A slow, steady bleed might not cause dramatic changes initially. The patient's body compensates, keeps the blood pressure up for a while. The danger is they can suddenly fall off the cliff, decompensate rapidly when those compensatory mechanisms are exhausted. Needs a high index of suspicion.
So how do you monitor for bleeding? How is it detected?
Close. Regular monitoring of vital signs is absolutely essential, especially in the first 24 hours. That means pulse rate, blood pressure, oxygen saturation, urine output, CVP if they have a central line. Just as important is regularly inspecting the dressings and any surgical drains. Is the dressing getting soaked? Is the drain output suddenly increasing or becoming very bloody?
If you suspect bleeding, what's the immediate response?
Get blood sent off urgently, full blood count to check the hemoglobin, coagulation screen to check clotting, and cross-match blood in case a transfusion is needed. Secure large-bore IV access, big cannulas straight away, and start fluid resuscitation to support their circulation.
What if you suspect bleeding inside, but it's not obvious where?
If the patient is hemodynamically stable despite suspicion, then imaging might be helpful. An ultrasound or a CT scan could potentially locate an internal hematoma, maybe one that develops a few days later.
But if the patient is unstable,
If they're showing signs of shock, or if there's a life-threatening situation, like that expanding neck hematoma we talked about, or brisk bleeding after a tonsillectomy, then there's no time for imaging. They need to go back to the operating theater urgently for surgical exploration and control of the bleeding source.
and the overall treatment approach for bleeding.
Two main arms. Stop the bleeding surgically, radiologically, endoscopically, whatever it takes, and provide aggressive supportive care, oxygen, fluids, blood products if needed to correct anemia or coagulopathy, and then ongoing close observation.
Blood transfusion often comes into play with major bleeding. What are the risks involved?
Transfusion is life-saving, but it's not risk-free. There are potential complications. Acute reactions like hemolysis, developing antibodies that could complicate future transfusions, fluid overload, especially in fragile patients, electrolyte issues like high potassium, a rare but serious lung injury called TALI, and historically, though very rare now with screening, infections.
Is there a specific level, a transfusion trigger, when you decide to give blood?
There's guidance, yes, but it's not just a hard number. The source mentions considering transfusion if the hemoglobin, the HB, drops below 8 GDL, and usually indicating it if it's below 7 GDL.
Right.
But the decision is always clinical. It depends on the patient. Are they actively bleeding? Are they showing symptoms of anemia, like chest pain or dizziness? Do they have heart failure that might not tolerate low HB? You might transfuse at a higher threshold in those situations. It's about balancing the need for oxygen delivery against the risks.
And for really catastrophic bleeding.
Every hospital needs a major hemorrhage protocol, a system for rapidly getting blood products, coordinating the team. In unstable patients with major bleeding, you need the consultant surgeon, the anesthetist, and often a hematologist involved very early on.
Okay, let's move to another well-known risk. Deep vein thrombosis, DVT.
DVT, a blood clot in the deep veins, usually the legs. It's significant because it can lead to pulmonary embolism, PE, which can be fatal.
So prevention must be absolutely central.
Absolutely paramount. It's considered a standard of care. Every surgical patient must be assessed for their risk of VTE venous thromboembolism, which includes DVT and PE, usually within 24 hours of admission. And that risk assessment needs repeating if their clinical situation changes. Then appropriate preventative measures, prophylaxis, are put in place based on that risk level.
What sort of preventative measures are used?
It's usually a combination of mechanical methods and drugs. Mechanical includes graduated compression stockings, sometimes called TED stockings, and intermittent pneumatic compression devices, pumps that inflate around the calves. Pharmacological prophylaxis usually means injections of low molecular weight heparin or sometimes unfractionated heparin.
Are there times when compression stockings shouldn't be used?
Yes, definitely. Important contraindications. You shouldn't use them if the patient has significant peripheral arterial disease, poor circulation in the arteries, or peripheral neuropathy, where they might not feel if the stockings are causing damage. Also, caution with fragile skin, allergies to the material, severe leg swelling, or major limb deformities.
What are the classic symptoms or signs of a DVT people look for?
Things like calf pain, swelling, warmth, redness, maybe seeing prominent veins on the surface. However, and this is another really key insight for mastering this, most patients with a DVT actually have no physical signs at all. It can be completely silent. The source mentions Homan's sign pain on flexing the foot, but notes it's unreliable.
So if you suspect it clinically, how is it diagnosed?
Clinical suspicion is often guided by scoring systems, like the 2-level DVT Wells score. It uses clinical features like recent surgery, cancer, swelling, tenderness to estimate the probability, categorizing it as DVT likely or DVT unlikely.
Right.
If the score suggests DVT is unlikely, a blood test called a D-dimer can be useful. If the D-dimer is negative, it makes DVT highly unlikely, though patients still need warning about PE signs. If DVT is likely, or the D-dimer is positive, the definitive diagnostic test is usually a duplex Doppler ultrasound of the leg veins. Sometimes phenography is used.
And if a significant DVT is confirmed, what's the treatment?
For DVTs involving the major veins, especially above the knee, the standard treatment is anticoagulation blood thinning. This usually starts with injections of heparin or low molecular weight heparin, followed by longer-term treatment with oral anticoagulants like warfarin or one of the newer direct oral anticoagulants, NOACs, following national guidelines. In some specific situations, like massive clots, or if anticoagulation is too risky, a filter might be placed in the vena cava vein to try and catch clots before they reach the lungs. It's also worth noting the source mentions how DVT risk varies by surgery type, classifying procedures as low, medium, or high risk, which helps guide how aggressive the prophylaxis needs to be.
That leads perfectly into the big worry associated with DVT, pulmonary embolus, PE. When does that typically happen?
Usually not immediately off the operating table, but often in the early postoperative days, maybe on the ward or sometimes even after discharge.
And the clot comes from?
Most commonly, it's a piece of thrombus that's broken off from a DVT in the legs or pelvis. Less often, it can originate higher up in the vena cava or even the right side of the heart.
What symptoms does a PE cause?
It really depends on the size of the clot. It can range from quite subtle symptoms like sudden shortness of breath, maybe a cough, sharp chest pain that's worse when breathing in, pleuritic pain, or if it's a massive PE blocking major arteries, it can cause sudden cardiovascular collapse and shock.
How is PE diagnosed?
Again, it starts with suspicion based on history, risk factors, recent surgery and examination, maybe looking for signs of a DVT. There's also a Wells score specifically for PE, using different clinical features to predict probability PE likely or PE unlikely.
What tests are done then?
Standard initial tests include an ECG, a chest x-ray, which might be normal but helps rule out other things, blood tests like arterial blood gases to check oxygen levels, and a D-dimer test, again, most useful if PE is considered unlikely. The definitive diagnostic imaging test nowadays is usually a CT pulmonary angiogram or CTPA. It gives detailed pictures of the pulmonary arteries.
And management if a PE is confirmed?
It depends heavily on how sick the patient is. If they're in shock, collapsing, then it's full resuscitation according to ALS guidelines. For massive PE causing collapse, thrombolysis clot-busting drugs is considered, but it's a major decision requiring senior input and adherence to guidelines. They might need drugs to support blood pressure, inotropes, and ICU care. For less severe PEs, supportive care is key: oxygen, pain relief. Once stable, the cornerstone of treatment is anticoagulation, similar to DVT, starting with injections, then transitioning to long-term oral anticoagulants. A vena cava filter might be considered if anticoagulation isn't possible, or if they have further clots despite treatment.
Okay, let's talk about fever or pyrexia. The source says it's very common after major surgery.
Extremely common. Up to 40% of patients apparently develop a fever postoperatively. And an interesting point, a key insight perhaps, is that often no specific cause, particularly no infection, is ever actually found. It might just be the body's inflammatory response to the surgical trauma.
Right, so it's not always infection. But what's the guiding principle when a patient does have a fever?
The absolute rule is you always have to look for a focus of infection. Even if inflammation is likely, you have to actively rule out an infectious cause first. Don't just assume it's inflammation.
What are the common causes of fever listed, both infective and non-infective?
Okay, infective causes include things like atelectasis, lung collapse, often cited as an early cause, wound infection, superficial or deep, infection specific to the surgical site, chest infection, pneumonia, UTI, thrombophlebitis, inflamed vein, often from an IV line, an anastomotic leak if bowel surgery was done, or collections of pus like abscesses. Non-infective causes mentioned include DVT, reactions to blood transfusions, hematomas in the wound, atelectasis, notice it's in both lists, can be inflammatory or lead to infection, and reactions to drugs.
If a fever persists, how is it investigated?
Requires a thorough clinical review, examining the patient carefully, looking at wounds, listening to the chest, etc. Standard investigations would include a full blood count, urine culture, sputum sample if they have a cough, and blood cultures to check for bacteria in the bloodstream. Imaging might be needed depending on what's suspected.
Next general complication, wound dehiscence. What exactly is that?
Wound dehiscence basically means the surgical wound comes apart. It can involve disruption of some or all layers of the closure.
How common is it? And is it serious?
The source quotes up to 3% for abdominal wounds. And yes, it's serious. It increases mortality risk, it's distressing for the patient, and often means further procedures and longer hospital stays.
When does it typically happen?
Most commonly occurs between day 5 and day 8 after surgery. This is a vulnerable period because the wound hasn't gained much tensile strength yet. The initial sutures are holding things together, but the body's own healing collagen is still immature.
How does it usually present? What are the signs?
Often the first sign is a sudden gush or increase in serosanguinous discharge from the wound that's thin, watery, pinkish fluid. The patient might even report feeling a pop or giving way sensation, especially if they coughed or strained. Sometimes this heralds an underlying abscess.
How is it managed?
If it's a full-thickness dehiscence of the abdominal wall, it usually requires going back to the operating theater for urgent resuturing. However, if the tissues look infected, unhealthy, or if closing it would create too much tension, the decision might be made to leave it open and manage it with special dressings, maybe a VAC, vacuum-assisted closure pump, to allow it to heal by secondary intention.
What makes someone more prone to wound adhesions? What are the risk factors?
There are general patient factors and local wound factors. General factors include things that impair healing systemically. Malnutrition, specific vitamin deficiencies, A and C mentioned, being on steroids, poorly controlled diabetes, obesity, kidney failure, jaundice, ongoing sepsis, cancer. Emergency surgery is also a risk factor. Local factors relate to the wound itself. Poor surgical technique in closing it under too much tension, issues that disrupt local healing like infection, hematoma, blood collection, or seroma fluid collection, and anything that increases intra-abdominal pressure, like chronic coughing from COPD or severe constipation.
Okay, last general complication on the list, pressure sores.
Yes, also known as pressure ulcers or bed sores. Patients are vulnerable if they're undergoing long surgeries where they lie still for hours, or if they have limited mobility afterwards. Pre-existing sores can also get worse.
How can these be prevented?
Prevention starts in the operating room with careful positioning on the table and using appropriate padding over pressure points. Postoperatively, the absolute key is early mobilization, getting the patient moving as soon as possible. Nursing staff also play a critical role with regular skin inspection, especially over bony areas, and frequent repositioning. For high-risk patients, special pressure-relieving mattresses, like air mattresses, might be needed.
What actually causes them?
It's usually sustained pressure, often combined with friction or shear forces, on the soft tissues overlying a bony prominence. This pressure cuts off blood supply to the skin and underlying tissue, leading to damage and breakdown.
Where are the common spots in someone lying in bed?
The classic pressure points are the sacrum, tailbone area, the greater trochanters, bony points on the hips, and the heels. But they can occur anywhere subject to prolonged pressure.
What else increases the risk besides just immobility?
Poor nutritional status is a major factor. Healing requires protein and calories. Dehydration affects skin integrity. And nerve blocks used for anesthesia can contribute if they cause prolonged immobility of a limb.
And they're graded. How severe can they get?
Yes, there's an internationally recognized grading system, usually based on the depth of tissue loss. Category 1 is just intact skin, but with persistent redness that doesn't blanch when pressed. Category 2 is partial thickness skin loss, like a shallow ulcer or an intact blister. Category 3 is full thickness skin loss, where you can see subcutaneous fat but not bone, tendon, or muscle. Category 4 is the most severe, full thickness loss with exposed bone, tendon, or muscle. There's a high risk of bone infection, osteomyelitis, with Category 4 ulcers.
Right. We've covered systemic and general issues. Now let's touch briefly on surgery-specific complications, as the source gives examples tied to particular operations, starting with abdominal surgery.
Yeah, after abdominal surgery, regular examination of the abdomen is key, checking for distension, tenderness, bowel sounds. Nasogastric tubes are sometimes used, especially after upper GI surgery or for bowel obstruction, or if someone has prolonged ileus or is at risk of aspiration due to reduced consciousness, they help decompress the stomach.
What about paralytic ileus? That seems common after abdominal ops.
It is. Ileus just means the bowel temporarily stops working, stops its normal movement. It's actually considered a normal physiological response for a short time after the abdomen's been opened, laparotomy, or the bowel handled significantly. Patients feel nauseous, might vomit, lose their appetite, their belly gets distended, and they don't pass wind or stool.
How's it managed?
Mostly supportive care, drip and suck is the old phrase. Intravenous fluids to maintain hydration, maybe nasogastric suction to stop vomiting, correcting electrolytes. But the really key clinical point is that if the ileus goes on for too long, it might be masking something else, like an intra-abdominal infection or an anastomotic leak. So while you support the patient, you have to actively look for other causes if it's prolonged. And if it is prolonged, they can't absorb nutrients, so consider intravenous feeding, parenteral nutrition. An interesting practical point is the order function returns. Small bowel first, then large bowel, then stomach last. That explains why someone might start passing wind but still feel nauseous the stomach isn't emptying yet.
You mentioned leaks. How does localized infection or an anastomotic leak present after abdominal surgery?
These can arise from leaks at surgical joints, abscesses forming, or even accidental bowel injury during the op. If it's localized, the patient might have tenderness just in one area, maybe spiking fevers, high inflammatory markers in their blood tests, sometimes positive blood cultures, and often that prolonged ileus we just talked about.
And the management for localized infection.
If there's a collection abscess that can be drained, that's often done using radiological guidance, like CT or ultrasound, plus antibiotics. However, if the leak or infection spreads and causes generalized peritonitis inflammation throughout the whole abdomen and the patient becomes septic, that's a surgical emergency requiring urgent laparotomy to find and control the source.
Bleeding is also a risk, specifically within the abdomen.
Yes, and it can be tricky. As we said before, the hemoglobin might not drop right away. Drains can get blocked and give false reassurance. You need a high index of suspicion if a patient has falling blood pressure, rising heart rate, increasing drain output if present, a distending abdomen, or a delayed drop in HB.
Moving to orthopedic surgery, what's the critical thing to monitor after limb surgery?
Neurovascular status. Absolutely vital after any surgery on an arm or leg, especially fracture fixation. Regular checks of circulation, pulses, capillary refill, color, warmth, and nerve function, sensation, movement, in the hand or foot distal to the surgery, both in recovery and on the ward. If a tourniquet was used, confirming return of good supply afterwards is essential. Documenting the status before and after surgery is crucial for comparison. Any concern about compromise needs urgent review by a senior surgeon. First steps might be splitting casts or loosening dressings right down to the skin.
Which leads directly to compartment syndrome again.
Exactly. The dreaded orthopedic emergency. Raised pressure within a muscle compartment, cutting off blood supply.
Remind us of the absolute key signs. The source emphasizes these.
Pain is the cardinal early sign. Specifically, pain that is out of proportion to the injury or surgery. Pain that is progressively worsening. And crucially, pain that is exacerbated by passive stretching of the muscles in that compartment. Those are the most reliable early warnings. The other P's, paralysis, paresthesia, numbness, tingling, pallor, paleness, and pulselessness, are late signs. If you wait for those, irreversible damage might have already occurred.
So vigilance and speed are everything.
Absolutely critical. High index of suspicion, early diagnosis, prompt senior involvement, initial management. Release all external compression, split casts, cut dressings, elevate the limb carefully, though not too high. Definitive treatment often involves measuring the pressures directly and surgical fasciotomy, cutting open the fascial envelope around the muscles to relieve pressure.
Next surgery, the big immediate worry.
Airway compression from a hematoma, bleeding accumulating in the wound. It's potentially life-threatening due to asphyxia. Hospitals need clear protocols for detecting this early and for emergency evacuation of the clot. Less immediately dangerous, but still important, is potential damage to the recurrent laryngeal nerve causing voice changes.
Thoracic surgery. Key points.
Careful fluid management is vital after lung resection, lobectomy, pneumonectomy, as patients can be prone to overload in the first day or two. Chest drains need regular checks. The fluid level should swing with breathing if it's in the right place. Bubbling indicates an air leak. Persistent bubbling might mean a bronchopleural fistula, a connection between airway and pleural space. Significant ongoing blood loss into the drain suggests hemothorax. Cardiac surgery patients need continuous ECG monitoring.
Neurosurgery.
Very close observation post-op. Any deterioration in consciousness level or new neurological signs could indicate rising intracranial pressure, ICP, maybe from a bleed inside the skull, intracranial hematoma. This requires urgent imaging and likely intervention to prevent catastrophic outcomes. Sometimes specific ICP monitoring devices are used.
Vascular surgery.
Focus is on checking the patency, the openness and blood flow through the repaired vessel or graft, done regularly using clinical assessment, checking pulses, limb perfusion, and often Doppler ultrasound.
Plastic surgery.
If flaps were used, monitoring their viability is key, checking their color, warmth, capillary refill, basically, their blood supply. This can be compromised by patient positioning, tight dressings, or fluid blood collecting underneath the flap.
And finally, urology.
Checking catheter patency regularly is important. After some procedures like 2RP, prostate resection, continuous bladder irrigation might be used to flush out clots. There are also specific complications like Tuer syndrome to be aware of.
Okay, great overview of surgery specifics. Now, some general postoperative problems and management principles. Let's start with drains. What's their purpose again?
Fundamentally, to prevent fluid collecting where it shouldn't, blood, hematoma, serous fluid, seroma, or pus, they drain it away from the surgical site. In some cases, like joint replacement, special drains allow the collected blood to be filtered and given back to the patient autotransfusion.
Has their use changed over time?
Yes, significantly. The routine use of drains in many types of surgery has actually decreased. Evidence started to question their overall benefit in many situations and highlighted potential downsides, so they're used more selectively now based on specific indications.
What are the potential downsides or complications of having a drain?
They can cause pain or discomfort. They can potentially cause trauma to nearby tissues when inserted or removed. And perhaps most importantly, they create a potential entry point for bacteria, increasing the risk of surgical site infection.
How does the fluid coming out help?
The amount and the type of fluid can be really informative. For example, after abdominal surgery, seeing bile or pancreatic fluid in a drain signals a leak. A sudden increase in bright red blood obviously signals bleeding. Tracking the volume and character helps identify problems early,
When do they come out?
when they're no longer serving a useful purpose and it's safe to remove them. The decision depends on the reason the drain was put in, the amount and type of fluid being drained. A drain managing a known fistula might stay for weeks, whereas one put in after a simple node dissection might come out in a day or two once output is minimal. You balance the need for drainage against the risks of leaving it in, like infection.
Okay, what about wound care? How does a simple closed wound start healing?
Right after closure, that little gap fills with inflammatory exudate. But the key thing is that within about 48 hours, skin cells, epidermal cells, migrate across from the edges and basically seal the wound superficially.
So that initial dressing put on in theater,
Should generally stay undisturbed for at least those first 48 hours because the wound is effectively sealed by then. You only take it down earlier if there's a specific concern like suspicion of infection or excessive bleeding soaking through.
when should wounds be inspected then?
Only if there is a concern increasing pain, redness, discharge, fever, or when it's time for a planned dressing change. And always using sterile technique to avoid introducing infection. If a wound looks inflamed, a swab might be sent for culture, though the source notes surface swabs can be unreliable if there's no actual pus. If there's clear infection or a hematoma causing problems, treatment usually involves antibiotics and potentially washing out the wound.
If you have to do surgery for a wound infection, what's involved?
Typically, taking proper samples for microbiology is crucial, ideally before starting antibiotics. Then, excising any dead or unhealthy tissue, debridement, controlling any bleeding points. If the wound is very contaminated or unhealthy, it might be packed open initially rather than closed directly with regular dressing changes until it looks clean enough for delayed closure or to heal on its own.
When do stitches or clips usually come out?
It varies. General guide is 6 to 10 days, but areas with excellent blood supply and low tension, like the face or neck, they might come out sooner, maybe 5-7 days. Areas under more tension or known for slower healing, like the back, they might stay in longer.
What things really slow down wound healing?
Several systemic factors. Malnutrition is a big one. Healing needs building blocks like protein and energy. Deficiencies in vitamins A and C are specifically mentioned. Being on steroid medication inhibits key parts of the healing process. And poorly controlled diabetes is a major impediment. It delays healing at multiple stages and also increases infection risk.
Right, once recovery is well underway, we think about discharge and follow-up. What's the essential paperwork for going home?
The patient needs a comprehensive discharge letter or summary.
What absolutely has to be in that letter?
It needs the final diagnosis, a clear summary of the treatment received, and critically, it must document any complications that occurred during the admission. It also needs to give clear advice to the patient about potential problems to watch out for and specific instructions on who to contact or when to seek readmission if those problems arise. This letter is also the main communication tool with the patient's GP, so it needs to outline the plan for ongoing care, any follow-up appointments, physio, community support. Relevant pathology results should be included, explaining how they influence the plan, and maybe a comment on prognosis if appropriate.
What about follow-up in clinic? What does that happen?
Typically, patients are seen back in clinic if there's a specific clinical decision that needs making by the surgical team, or if they need to assess the outcome of the surgery or monitor healing longer term, things the GP can't manage.
And after that clinic visit?
The outcome and plan need documenting clearly in the patient's record, and again, communicated back to the GP via a clinic letter. The patient should also be reminded about potential complications and what to do. Once the surgical team feels their input is no longer needed, the patient is formally discharged from surgical follow-up back to the care of their GP or self-management.
Finally, let's look at ways to potentially speed this whole journey up. Enhanced recovery. Speeding the journey. What's the philosophy here?
Enhanced recovery, often called ERS, enhanced recovery after surgery, is a whole package. It's a multidisciplinary, evidence-based approach to the entire perioperative period. The goal is quite simple. Speed up the patient's clinical recovery, which tends to mean shorter hospital stays and lower costs.
How does it actually achieve that?
By combining two main things, optimizing the patient's health before surgery, that prehabilitation we talked about, and then consistently delivering the best evidence-based care during and after the operation. It's about minimizing the physiological stress of surgery and supporting rapid return to function.
What are some of the specific postoperative strategies used in ERS pathways?
Key elements include early and planned mobilization, getting patients up and walking soon, early return to eating and drinking normally as soon as it's safe, using pain relief strategies that minimize opioids, things like regional nerve blocks, paracetamol, NSAIDs, and very proactive discharge planning, often starting even before admission, involving physios, specialist nurses, community teams to get everything lined up for a smooth transition home.
You mentioned early mobilization. What are the specific benefits of getting people moving quickly?
It's a cornerstone because it actively prevents common problems. It reduces the risk of DVT, urinary retention, atelectasis, lung collapse, pressure sores, and constipation or fecal impaction. Movement is key.
Is there follow-up after discharge in these pathways?
Yes, structured follow-up is often part of it. Telephone calls are commonly used a few days after discharge just to check in, see how the patient is recovering, answer questions, and catch any early problems.
Wow, okay. That was genuinely a deep dive. We really went through the layers of perioperative and postoperative care there.
We started broad, right? Defining perioperative care, the team, and hammering home the importance of that pre-surgery optimization and prehab phase.
Yeah, then straight into the immediate aftermath, the critical handover, the detailed monitoring, those early warning systems like NEWS2, which are so crucial for catching problems early, and the clear criteria for moving out of PACU safely.
And then a huge chunk was dedicated to complications, wasn't it? How we try to predict risk using tools like ACS, NSQIP, how we grade severity with Clavian Dindo, and then methodically working through potential problems system by system. Respiratory, cardiovascular, renal, neuro, bleeding, clots.
Right, covering the big hitters like DVT and PE in detail. Plus those general issues like fever, wound problems like dehiscence, pressure sores, and the thinking behind managing drains and wounds, all drawn directly from that source material.
And we didn't forget that complications can be specific to the surgery type, hitting examples from abdominal, orthopedic, neck, chest, neuro, vascular, plastics, urology, highlighting the specific things to watch for in each case.
And finally, bringing it back to the end of the hospital journey, discharge planning, follow-up, and those enhanced recovery strategies that aim to make the whole process smoother and faster.
Exactly. And understanding this level of detail. It isn't just theoretical. This is the knowledge base professionals use every day to anticipate problems, to spot those subtle warning signs, to intervene effectively, and ultimately to make decisions that have a massive impact on whether a patient does well or not. By digging this deep, you're really getting insight into the core knowledge they strive to master.
It definitely feels that way. Thinking about all those interconnected systems, all the potential failure points, how one event surgery can ripple through the entire body, it makes you reconsider what recovery even means, doesn't it? It's clearly not just passive healing. It's this incredibly complex, active, and sometimes fragile process. For you, looking at this whole intricate picture, what stands out as maybe the most significant piece of that puzzle?